So beginning with a MACI for the patella, the first step is essentially just to take a quick look arthroscopically. The main point of the scope is just to look at the other parts of the knee that you may not see as often you're making a smaller arthrotomy. Also, often quite helpful to take out loose bodies. I've certainly seen loose bodies that were not appreciated on MRI. Here is a small lateral arthrotomy. This was done through a lateral lengthening incision. And you can see I take a marking pen and just mark out the far edges of the defect to make sure that I do get them. I typically start with pickups and a scalpel and then go to using a curette. The varicella cookie cutters are helpful to get a clean, reproducible defect. Here you can see placing fibrin glue in the defect. You want to make sure that you get down to the calcified cartilage, but not down to bleeding bone. Here you can see placing the MACI into the defect. I place the MACI into the defect with a piece of Esmark that helps me bring it down without having to actually touch the graft. And here it's just checking for stability in the graft. I make sure that there's no wrinkling. And here just using a Wexel to dry it off. Often I do this with the tibial tubercle osteotomy. Here's just a cadaver video so you can see quite well. This is a distalizing osteotomy where I first mark it out with a bovie and then a saw and osteotomes. You can see me marking the distal aspect to take an additional centimeter. I do a chevron osteotomy. Here you can see me completing the osteotomy distally once the proximal aspect has been completed, elevating up and taking away the wedge, which you can see on the right here. I use an Evans wedge for allograft bone to buttress it proximally. This is both for stability and healing. I have seen these break up to 10 years out if they're only healed distally. I think this is quite helpful. And then I bring the periosteum over the distal aspect of the graft, adding in an MPFL. Here you can see just a small medial arthrotomy. This is extracapsular. I prepared the bone with a bovie and a curette, and I use 2 all-suture anchors. I typically use a gracilis graft. Here you can see me marking the central aspect of the graft and then tying it down to the proximal 50% of the patella. I then whip stitch the distal aspect of the graft with the fiber loop suture and size it. I bring that suture around a or adjustable loop implant. I then place a guide pin between the adductor tubercle and the medial epicondyle, and then check isometry. Here you can see me passing the graft superficial to the capsule. I mark the graft and check isometry. Typically, I also check fluoro after this step, and then I ream to the appropriate size, bring through a looped suture, and then subsequently pass my graft. I'm in an effort not to over-tension the MPFL, I place a snap under the graft medially as I tension the button laterally. This allows me to fine-tune it